Yeah, difficult question. These are my disclosures. So when I give this presentation or gave this presentation, let's say less than 1 year ago, it was a quite easy presentation. Here you see the 3 doors, the 3 choices, and all 3 doors were open, DCB, DES, BMS, and we had in our service a quite simple treatment algorithm. We did, as we've heard, intensive vessel prep, and then afterwards we decided if there was a flow-limiting dissection or residual stenosis over 30%, yes, then we need a scaffold, and we use drug-eluting stents. If there was no problem after vessel prep, we used the DCB, and if necessary, we did a bailout stenting with bare metal stents. Very easy, straightforward. But unfortunately, in December last year, we had this Greek tragedy about paclitaxel. And so this was, of course, changing a little bit my treatment algorithm, and especially after the recommendations of the FDA, and more specifically after the recommendations of the Belgian authorities, and I'm going to share this with you, I needed to review my treatment algorithm. So here you see the last FDA recommendation, August, a little bit different as what we've seen in the second one in March. It was for most patients. Now we have to take care for many patients and to look at alternatives. But still, the patients at high risk for restenosis and repeated interventions can be treated with paclitaxel-eluting devices. But here you see the Belgian recommendations in July the 3rd, 2019. Very simple. Do not use paclitaxel, DCB, and DES as your preferred treatment for intermittent claudication until further notice. So nothing is mentioned about high risk for restenosis or high risk for repeated interventions. So this is the situation we have in Belgium. 2 doors are closed, and we have only the door of POBA and bare metal stents. So how to continue now as an endovascular-oriented vascular surgeon? Well, 3 questions. First of all, what to do with heavily calcified lesions? Is the lesion calcified, yes or no? Is it a high-risk patient for restenosis? And is it a responder to vessel prep? A little bit summarizing the topics that we covered today. Unfortunately, the 3 questions can't be answered most of the time with very clear, objectively defined criteria-based answers. What makes it appropriate treatment choice not always easy. Heavily calcified lesions, as you can notice here, there is no discussion in this case, but there is a lack of objective quantitative vessel calcium measurement. Here you see some grading scales and some recommendations, the PAC score, the PARC score, and the compliance 360-degree score, all summarizing that if you have a bilateral calcified wall of the vessel on plain X-ray or more than 180 degrees circumference, we can speak about severe calcium. So let's keep this as a rule. High risk of restenosis. A lot of publications are over there. When I try to summarize it a little bit, what I found in literature, well, there are patient-specific factors and lesion-specific factors for high risk of restenosis. CLI, diabetes, end-stage renal disease, and poor runoff, versus also length, small vessel diameter, and occlusions. What about vessel prep responder? We already had the question. How can you judge finally if the patient is a good prepping responder, yes or no? Quite difficult to say, because there is no consensus on stent requirement, there is no clear definition, should a dissection be treated or observed, and how to improve procedural hemodynamic assessment and related stenting approach. So, is it a 2-projection angiography, eyeballing? Is it intraoperative duplex ultrasound? Is it intravascular ultrasound? Is it pressure measurements intraluminally? We don't know, and we try with the BioReact pilot study to have some answers on this. So based on these 3 questions, I tried to make an algorithm, a treatment algorithm. First question, is it severely calcified? If yes, is it an angioplasty responder? If yes, then we go for a Supera treatment. Why? Because we have the data, as you can see out of the SUPERB trial, and also in longer lesions, Supera 500 and Supera 500 long lesions, that we have quite acceptable primary patency rates around 80 to 85%. other data in severely calcified lesions of the SUPERB trial, you see that we still reach a patency of 89% after 1 year. One condition, you need to implant it nominal and not in an elongated way. So it has to be an angioplasty responder. If it is not an angioplasty responder, then you need to choose another vessel prep tool. If it is focal, in my opinion, you can use atherectomy and then afterwards supera implantation. If it is, here we've already heard the importance of creating a wider lumen, an increased lumen gain, that it has its influence on improved patency. Here another example where you see that the lower the residual stenosis you have post-directional atherectomy, the better your freedom from TLR at the end. If it is diffuse, non-responding calcium, in my opinion, the atherectomy devices on the market are not the ideal tools to prep the vessel. And then we are using or the pave and crack technique, or don't forget, as a vascular surgeon, you still have the bypass opportunity. So the pave and crack technique, where you implant a Viabahn and then you treat the vessel with balloons, extremely aggressive. You rupture the vessel within the Viabahn, and afterwards to create some extra crush resistance, you implant supera. Here you see the results, preliminary results in small amount of patients, of course, because it's a new technique, but more than acceptable. If it's not severely calcified, the lesion, then you have to ask the question, is it a patient and a lesion at high risk for restenosis? If yes, then you need to prep the vessel anyway, and I try to continue to implant in these cases, following the FDA recommendations, a DCB based on the literature we have available, and if it's a non-angioplasty responder, a DS, as we know out of the literature how good the results are. If the patient is not at high risk and it is not severely calcified, then I try to treat my patient with a bare metal stent with a correct chronic outward force, as we know that also this criterion is important for the outcome afterwards. And so finally, as a conclusion, we can conclude and then probably also discuss this final treatment algorithm based on the FDA recommendations and also based on the 3 questions: calcium, angioplasty responding, or at high risk for restenosis. I thank you for your attention.
Great. Thank you very much.